TASH 2024, we have seen that the revolution in multiple myeloma is continuing, and particularly we have seen outstanding novelties in different settings. Starting from early stage myeloma and in high-risk smoldering myeloma, we have seen really super interesting results. Starting from Aquila study, in which we have seen a wonderful result with daratumumab in high-risk smoldering myeloma compared with the observation, and I think that this will be the basis for the registration of anti-CD38 monoclonal antibodies in pre-myeloma status, and I think that waiting for Ithaca trial that maybe will be the real game changer, in which isatuximab is combined with lenalidomide dexamethasone versus lenalidomide dexamethasone, waiting for its interim result. I think that monoclonal antibody should be the present of the treatment for these patients. Together we have seen also really interesting results with the carfilzomib lenalidomide dexamethasone versus lenalidomide dexamethasone, same setting, high-risk myeloma. Also cilta-cel giving almost 100% of response. I think that according to all these combinations evaluated in this setting, we should be more and more ambitious, and the real endpoint should be MRD negativity, because they should have a really long-term control in order that these patients will never develop symptomatic multiple myeloma. One question has been solved. I think that no one has duped today in sense of treating or not treating high-risk smoldering myeloma. We should absolutely treat the patient, and we should make democratic the treatment available everywhere. In terms of frontline multiple myeloma, we have seen really outstanding result with the isatuximab combined with the VRD in GMMG HD7 clinical trial that has shown incredible results not only in terms of overall response rate, but also MRD negativity, almost the double than the control arm. And moreover, we have seen that these data are maintaining in a long-term analysis, also according to a new kind of maintenance in which isatuximab is combined with lenalidomide versus lenalidomide alone, and this is a new randomization that shows improved response in patients that have a more dense maintenance. I think that this is the basis to obtaining transplant-eligible patient the best response as possible, which correlate with the best long-term outcomes. In terms of relapsed and refractory setting, we have seen at first CAR-T used also in early stage. CARTITUDE-4 has shown the superiority of CAR-T versus standard of care, and I think that this will be cilta-cel the next future also in patients that are not in heavily pretreated situation but are in early relapse setting. We have seen outstanding results also with different molecules, and in particular I appreciate mezigdomide that has shown incredible results with a wonderful tolerability and a very good compliance. We have seen again the reworking of belantamab mafodotin with incredible data also in terms of first analysis of overall survival, and we are going to see also new bispecific antibodies such as ABBV-383 with incredible tolerability and also overall response rate. The combination with the daratumumab of this molecule is, in my opinion, one of the best novelties that we have seen in this conference, and also belantamab mafodotin data in terms of overall survival. We have seen the first analysis in this sense is showing again the reworking of this drug together with bortezomib dexamethasone. Let's not forget the combination data of elranatamab. Magnetism 20 is a phase 1b clinical trial in which elranatamab has been shown in combination with the carfilzomib, also in this case outstanding results. Another interesting study has shown the evaluation of bispecific antibodies in academic center versus community centers, and we know that there is no difference, and these drugs can be performed everywhere, also in elderly population. So no stopping in using these outstanding drugs in every patient that need, because there are no problems in terms of kind of institution and also in terms of age of the patient. In the patient that need this treatment, we can use without any problem. I think that also the real-world analysis of CAR-T is really interesting, and we have seen shown a superiority of cilta-cel versus ide-cel also in real-world setting. And I think that this should be in some way inserted also in a world in which new drugs are arriving. We have seen the first data with academic CAR-T that are feasible, are cost-effective, and I think that also institutions like mine are working in this sense, and I hope to show results as soon as possible according to our approved cell factory. First data with the 3 specific antibodies, another novelty that we were strongly waiting for, and I think that all of these novelties are running to better personalize as soon as possible the treatment of our patient. Sequencing became essential, in particular to discriminate the setting. We have seen also data that cover another really important unmet medical need, extramedullary disease. It seems that new CAR-T are going to give exciting results also in this setting, and we are also answering to the question which is the best bridge to CAR-T. Maybe talquetamab has shown the best results in this setting. Let's not forget also the positioning in these patients for selinexor or melflufen that can be also really good in this situation. And all these novelties to see that this is a really exciting ASH, and myeloma is on the top maybe of the novelty, and all these outstanding results to hope that as soon as possible we will reach the cure, and this is the best wish for our patients, for their caregivers, and for all myeloma researchers.